Good morning, everyone, and welcome to the morning grand rounds. Before I have Dr. Al-Sadawi introduce our guest speaker, I just want to review a few important things. Mostly that Dr. Yader Sandoval, through no surprise, has been appointed the social media editor for Jack Journal. So those of you that want to get your name out, we can put you in touch with Yader. I think many of you may have noticed the New England Journal of Medicine article recently outlining the improvements with the HeartMate 3 device. Peter was a PI on that, were you not?
Moody was the site PI.
Yeah, and Carl Moody were the site PI, so we were involved in that study. And then Paul Saraja and Manos and Peter Toddy were involved in the SCI conference in 2018 here with 2 live cases. And our publications continue to be strong through the year, 52 publications so far through the first quarter. So we're off to a great start. And we're off to a great start with our grand rounds this morning with Saeed has invited one of his friends from Rochester on a timely topic.
All right, good morning. So it's really a privilege to introduce a friend and a mentor from Mayo Clinic, Dr. Pislaru. Sorin is originally from Romania. He went to medical school at Carol de Villa University and then went to Belgium and did his PhD at University of Leuven. He's been at Mayo Clinic since he moved to the United States. He did his internal medicine, cardiology training, and then he stayed on staff. He's currently a professor of medicine at Mayo in Rochester, and he directs the research for the Division of Cardiovascular Ultrasound. People who know that division, when I was there are at least 20 research fellows. It's hard to keep track of them. They're from all over the world, so Sorin directs that unit at this point. He's going to talk to us about bioprosthesis thrombosis. It's a hot topic these days. He's actually contributed to most of our knowledge in this topic. So when Dr. Sharkey asked me to invite somebody about this topic, I immediately thought about Sorin. So we look forward to your talk, Sorin.
Well, so first of all, can you guys hear me or am I on? Hard, loud enough? Okay. So thanks a lot for the invitation. It's really a privilege to be here this morning, and we hear a lot of things of what you guys do, and I would say they are truly amazing. We have good friends here. Saeed, it's not the only one. Paul Saraja, Mario Gosal. So they threaten me that they'll give me a hard time. I don't see them quite yet. But anyway, so I'd like to share with you a couple of things we learned over the last 5 years about bioprosthetic valve thrombosis. And this was very much an entity that didn't exist, or at least didn't exist 10 or 15 years ago. So we're going to go through a couple of things. Does it exist? What is the timing of bioprosthetic thrombosis? How to diagnose that? When to image it? Some treatment options and some take-home points. So does the valve bioprosthetic thrombosis exist? And obviously it does, but sometimes it's easier to spot it and sometimes it's harder to spot it. Now I would like for you to start by looking at these 2 patients who are eerily similar. They are both in their 70s, both had aortic valve replacement, the one on the left through TAVR, the one on the right through STAVR, and they both had an increase in dyspnea, and they both have a systolic ejection murmur. We still examine the patient, even if you have echo. And this is what you get on the transthoracic. So not much, but you do get a gradient of 40 from a baseline of 12 on the left side and a gradient of 42 from a baseline of 15 on the right side. Just look carefully, and if you see it and if you spot it, keep it for yourself and think what you would do, what you would diagnose in this patient. And if you go to transesophageal echo, it doesn't get much easier because it is hard to image an aortic prosthesis, whichever way you cut it. Just look on the left side. Both patients have normal LV size. Both patients have normal EF, if not hyperdynamic, like most of the patients who have aortic stenosis do. So the question that comes to mind is, did you see enough to make a call? Would you call this a bioprosthetic thrombosis? Would you feel comfortable with that? All right. So these are the things that come to mind whenever you have an increased gradient through a bioprosthetic valve. Could this be early bioprosthetic degeneration? It could. We've seen it. We've seen it as early as within the first year. Thanosine growth, pressure recovery, unrecognized regurgitation is on the list. The famous patient-prosthesis mismatch people keep talking about, high cardiac output. But finally, you have now bioprosthetic valve thrombosis. So anybody who thinks the patients have bioprosthetic thrombosis on the left side, yay, nay. Think for yourself, yeah. How about the right, the one on the right side? He thrombosed. No. Well, so that was the initial call, and I can promise you that both have bioprosthetic valve thrombosis. And the reason I didn't, I was a little mischievous. I didn't show you everything we had, because if you look back at the short axis view, the leaflets at the edge are thin and not involved. They are not thrombosed, and this is how it looks like in the long axis view. And you need to be careful with that, because the initial call, the page I got from the cardiologist doing the study was, there's no thrombus. And then we looked some more with Larry Sinek, who you may not know, but he's probably our most senior echo guy. And finally it was, well, I guess we do have it. Now, I wouldn't show these cases to you if I couldn't prove that they do have thrombosis. And we know that because the one on the left actually went to surgery. It was one of our very first studies. It was a massive increase in gradient. Patient was not doing all that well. So decision was made to go back to surgery. And this is how the valve looks like. This is typical of bioprosthetic valve thrombosis. You can see here the thin leaflets, and the thrombus is all in the body of the cusp. That's where the thrombus resides. And that's the reason on that short axis view that you saw on the patient on the right side, the leaflet edges, if you just cut through exactly that one plane, you won't see it. So don't get fooled by that. And the patient on the right side, we actually treated with warfarin, and he had a steady decline in the gradient, and he's down to 14 millimeters of mercury after about 1 year. And he just came to the clinic 1 month ago, 7 years after the initial event. So he's doing still very, very well. So he's a success story for bioprosthetic thrombosis. So how about timing? So this is our first paper on the topic, and it took a while to convince people to even consider it, to even take it. It went from all sorts of journals down and down and down until it made it into the European Journal of Cardiothoracic Surgery. So at least it got through. It was a lot of pain involved. So what we had there, we looked at the Mayo Clinic records for 16 years. And what we essentially did, we Googled the medical record for predefined terms. So if you look for all sorts of things that may pertain to bioprosthetic thrombosis, and we presumed a diagnosis of bioprosthetic thrombosis if the patient had echocardiographic features consistent with thrombus and they responded to medical therapy. And of course, confirmed cases if they went to surgery and now you have an explanted valve and you can tell for a fact if it was thrombosed or not. So out of those 220 patients that we found in 16 years, so 220 patients, 16 years. That doesn't seem a lot. So I identified 31. 17 were treated with either surgery or lytics, just 2 with lytics, and 15 managed initially with warfarin anticoagulation, and 17 plus 15 is 32 because one patient actually had 2 events. So for one was treated with surgery, for the second one was treated with warfarin anticoagulation. So it was including both groups. So these are some examples. Just look at the mitral valve prosthesis. This is a patient who is ready to go home. He had a 29 millimeter Hancock prosthesis, and you don't see much on the mitral valve here. If you zoom up though, you can appreciate that there is restricted mobility of the leaflet. You cannot tell for a fact there's thrombus on the leaflet, but you can see the restricted opening, and that will fit with the gradient. And that should certainly raise suspicion for bioprosthetic valve thrombosis, because this is what you get if you go to the transesophageal. You see an immobile leaflet that's a little thicker than the contralateral one that moves. So that's bioprosthetic thrombosis. And if you zoom some more, you see it even better. And since you have 3D, we play with the tools we have, and we have one cusp that's immobile and 2 that move. Is it only in the mitral valve or aortic valve? No. Every single valve we looked at, every position we looked at, can have bioprosthetic thrombosis. And this is a tricuspid bioprosthesis. Again, with transthoracic images, I do not know how well it projects, but you can imagine that there is not a lot of opening here, so hard to tell, hard to tell. But what's striking is the color, really. This makes the difference between echo and CT because you have instant gratification. You turn the color on and you will know the gradient is there or the gradient is not there. And in this patient, if you go to transesophageal echo, again, you see the typical thrombus in the body of the cusp. And not very common, but not unheard of, you have large layer thrombus in the atrium above the valve. So this doesn't happen for aortic and pulmonic valves. It only happens for tricuspid and mitral valves. But you see it time and again. So one misconception is that bioprosthetic thrombosis occurs within the 3 months, and a lot of the CT literature will beef up that appreciation that you should worry about thrombosis about the first 3 months. And we know all why, because the valve is fresh, it needs to be re-endothelialized. And after all, that is the very reason why we recommend anticoagulation for at least 3 months in everybody who gets a valve. Now look what happened in our initial series, 31 patients. So it turns out that most of the patients, the bulk of the patients were diagnosed in their second year post-implantation. So this is way past their original surgery. And actually, the longest in this particular series was 6.5 years. And the longest I'm aware of that looked very, very convincing valve thrombosis was about 11 years. So it's a lot late. Later than what people usually think. So that was the first misconception. How do you diagnose the bioprosthetic valve thrombosis? So based on our initial series, we said, okay, let's take 3 simple things on echo. Let's take an increase in gradient more than 50% over baseline. So yeah, just use your best judgment. If your gradient after prosthetic valve in aortic position was 10 and it goes to 19, that doesn't really, that makes the 50% increase. If it goes back down, probably will make the diagnosis too. Look at thickened but not calcified leaflets. If you have echo bright densities on the leaflets, that's probably going to be a degenerative valve. Look at restricted leaflet mobility. And if you have all 3, probably you're looking at bioprosthetic valve thrombosis. It's all fine and dandy when you look backwards, but the question is it going to hold? So let's see a more systematic series. So what Alexander Egby did when he was still a fellow before becoming a staff cardiologist in congenital group was look at every single reoperation for bioprosthesis. So he identified in almost 2 decades about 460 reoperations for bioprosthetic valve. And it turns out that about 11% of the reoperations are due to prosthetic valve thrombosis. And this is all no question asked. There's a pathologist who signed off on that. You know, Mayo Clinic, they have everything. They keep everything. So the valve is physically there. You can go back and look at it. And there is thrombus as a main mechanism. And all patients who had endocarditis were excluded, or patients who had mixed feature, both degeneration and thrombosis, were excluded. So this is just pure thrombus as a reason for reoperation. So perhaps this is not as uncommon as we thought it was. So what Alexander did was match the 46 patients with bioprosthetic thrombosis with 2-to-1 for the same position for age and gender. Patients who did not have thrombus. And what he found was that these 2 diseases are very, very distinct. On the right, you have bioprosthetic degeneration, on the left, bioprosthetic thrombosis. And you can appreciate from the pathology specimen that the difference is there. So there's panicing growth. Sometimes you have calcification of the leaflet. On the left side, you have that thrombus deposition in the body of the cusp. And if you look at the timing of the event, what you notice is that bioprosthetic valve thrombosis occurs much earlier than degeneration does. And indeed, in this series, just like in our observational mixed 30 patients early report, the median time to thrombosis was about 2 years, whereas the median time to degeneration was about 9 years, 9.5 years. So there's a difference. So bioprosthetic valve thrombosis occurs earlier. Another misconception was that bioprosthetic thrombosis must be easy to diagnose. So we said, okay, we proud ourselves with the quality of the echoes we do. We thought, a thorough job. How did we do in this particular situation? So for transthoracic echo, every single report had an abnormality. So no report said the valve is structurally normal. And of course, all these patients had increased gradient, so you have to say something about that. But bioprosthetic thrombosis was not suspected in 95% of the times. Not only that, but if you look at the transesophageal echoes, the original echo report quoted bioprosthetic valve thrombosis as a possible mechanism in only 1 in 10 patients. So we didn't do a great job at that. And if you look back at the images, and we have digital images for the last decade, and I did look back, in a blinded fashion, you can say that most of the mitral and tricuspid valves had evidence of bioprosthetic thrombosis that was not recognized. And for the aortic valve, it was a little harder to see the valve. So sometimes you can tell, sometimes you cannot tell. But the conclusion I had about all this is not a failure of echo. This is a failure of a physician. Because what happens is the eyes will not see what the mind doesn't know. So if you do not know of a disease, you will not call on that. So I think that was the major reason why we had under-recognized bioprosthetic thrombosis. So how did those 3 criteria that we proposed hold up in this series that was a little more systematic, and that includes non-thrombosed valves? Well, it turns out that it held pretty well. If you had all 3 parameters, the sensitivity was 72%, and the specificity was about 90% to diagnose bioprosthetic valve thrombosis. So 3 criteria: gradient high, thickened non-calcified leaflets, restrictive leaflet mobility. All 3 of them, you're pretty good that you have thrombosis. And now let's look back at those patients. Because if you see here, the thin leaflets, the thick leaflets here, this is typical of valve thrombosis, thickened leaflet, whereas here on the degeneration, you have thick but echo-bright lesions. So that is not a thrombus, that is a degenerated prosthesis. You can see it very, very well in the long axis. Degenerated, calcified lesion. Don't spend your time trying warfarin on these patients because you will gain nothing out of that. Now, CT is emerging, and really CT is a great technology for a lot of things, and for valve thrombosis in particular. In aortic position, I think it is probably the way to go. So it has better delineation of cusps. You have less acoustic shadowing. You still have some shadowing you still have some artifacts from the device. They are called all sorts of ways: hypoattenuating leaflet thickening or halt, hypoattenuating mass or ham, so all sorts of sandwich reminding kind of thing. But what it does fairly well, better than echo, the distinction between calcification and non-calcification soft tissue. And I think CT really has an edge in that. Now, there's a learning curve for that, and I'll touch on that. And there's a word of caution on that, and I'll show you a couple of cases for that too. So, of course, the first CT major paper was the Raj Makar New England report of 2014. And what happened is that Raj looked at the Portico trial, so the 55 patients in the TAVR trial were with the Portico valve, and they detected 40% hypoattenuating lesions on the prosthetic valves, and that's the reason Portico trial was stopped early. And in the registry, when they looked at that, they had an incidence of about 13%. And what they noticed was that if you were on warfarin, the incidence was 0 in that particular series. So the paper went on. There's an online supplement if you want to look for it, where they did some modeling in a bench, and they had 1 cusp immobilized and 2 cusps immobilized. And what they said was, If you only have one cusp that doesn't move, that does not increase the gradient all that much. It does, but not to a big degree. If you have two cusps, that's when you start seeing the obstruction based on gradients. And these are the images, and thank you, Microsoft, for being so slow. Or maybe it's just the fact that I downloaded them from New England. Meanwhile, we started our own CT, and actually that shows a little better. So let me show you one of the studies that we've done last year. So this is a freestyle prosthesis, and I'm going to freeze the image in the long axis view. And you can see here the thickened leaflet. Of course, this is in diastole. But you can see the thickened leaflet, and there's something on the valve. And I actually think that the series of shortcuts through the valve are the ones that tell the tale. Because now you can see clearly the non-coronary cusp is thick and immobile. So now you have a diagnosis of prosthetic valve thrombosis by CT. I didn't put up the TE images. They were fairly good on this. Freestyle prosthesis is fairly easy to image by TE. So we had the diagnosis by two imaging modalities that this is really a bioprosthetic thrombosis. So is this real? And this is probably true that you have subclinical thrombosis before you have clinically manifest thrombosis. And this is work done by a couple of our fellows over the last 6 months or so. You know, Mayo, we do echo at the drop of a hat, and maybe that's a good thing on occasion, because you have data to look back and forth what happens with the patient. And if you take the patients who had aortic valve bioprosthesis, and you say, I'm going to say time 0 is the time of diagnosis, you see the gradients are in the 40s, so everybody is aware at this time. But if you look back, the gradients were higher even before. And the reason you have so many echoes is because people see a gradient and say, what's going on? I don't know. Let's look again. Come back in 6 months. And then eventually somebody thinks, oh, I guess this is bioprosthetic thrombosis. Let's try and treat it. And treatment actually does work because it decreases the gradient. And it's the same for mitral and for tricuspid. You see the slight increase in gradient precedes the timing of diagnosis. So there's a signal in there. We were just unable to pick it. Now, if you have a valve that has a gradient of 3 in mitral position and your gradient is 5 at follow-up, would you be alarmed about that? Would you just blame it on the heart rate? Well, I guess if your heart rate is not high, if your cardiac output is not high, if your hemoglobin is not low, if you have no other reason to suspect anything else, maybe you should think twice why that gradient went up for a certain valve. We don't know about pulmonary valves. Well, we only had a couple, 3 cases of pulmonic valve thrombosis, so one would suspect that it follows the same pattern, it's just we don't have data on that. So there's an element of subclinical thrombosis. Now, the same group from the partner trial looked again at a much larger registry, 930 patients, and they said CT interpretation is very good quality 96% of the time, which is good. They called 12% subclinical thrombosis, but the interesting part of that is that some patients who were on anticoagulation had valve thrombosis, which is contrary to the earlier report. Importantly, they said that everybody who was treated with anticoagulation once the diagnosis was established had a response. So with warfarin, and to my knowledge, this is one of the very, very few papers documented that NOACs were used for bioprosthetic valve thrombosis. It's 12 cases, that's it. The same type of approach from the group in Rotterdam with Jerome Bax as a senior author. They looked again in a registry fashion at 400 and some patients. They have almost the same percentage of bioprosthetic thrombosis, 12.5%. Interestingly enough, what they noticed, there's no difference in terms of stroke or peripheral embolism if you do or don't have this valve thrombosis based on CT. And interestingly enough, these are patients who are not formally diagnosed. There's no formal treatment. It's all retrospective. But only 3% of these patients still have that lesion on a CT at 3 years. So it's kind of hard to understand what exactly is going on. And I would volunteer that perhaps, just perhaps, some of the CT studies over-diagnose bioprosthetic valve thrombosis for this very next reason. So, not every immobile cusp is a thrombosed valve. And I think this is something that the CT community needs to learn, just the way the echo community learned the hard way initially. So look at this particular patient. So this is a valve-in-valve implantation. It's a sapien done transseptal into a mitral calcified valve. And what you see at the implantation, it's all fine and dandy, perfect result, nice imaging, even if I didn't do it myself, so I still have to appreciate that. And both leaflets are opening symmetrically, and I'm going to freeze it on the 3D, maybe in an open position. There. So let's see what happens 4 days later. So the patient is anticoagulated, is on heparin because it's a history of stroke. Look at the cusp. What gives? Thin, immobile at the base. Thin, immobile at the base. 2 of them. 2 of the 3. So what gives? What happened to this patient? And what we thought happened was actually there's a little recoil inside of the calcified annulus with pressure on the valve stem and a little indentation in the posterior aspect of the valve. So that changes the geometry of the valve, and 2 of the cusps do not move all that great, even if there is no thrombus in there. And I can promise you the APTT was therapeutic in everybody. Well, so let's look at another case. So this is a case that comes off bypass in the operating room. So Sari Padank, who's one of our staff members now, did the study. So I promise you the ACT is just about 1 billion seconds. Okay, so they are on full everything, on pump. They just go off bypass. 1 cusp is immobile. 1 cusp is immobile. Doesn't move. There's nothing wrong. There's no thrombus on that valve. It doesn't move. So not every single leaflet that doesn't move is a thrombosed leaflet. Look at this case. Bioprosthetic thrombosis in 2012. This is one of my patients. I apologize for the quality of the images, but essentially I'm going to freeze it here. 2 cusps of the 3 immobilized. She has bioprosthetic thrombosis. So the aortic valve is here on the top, so we'll call it anteromedial, anterolateral cusp immobilized by bioprosthetic valve thrombosis. We treated her, kept her on warfarin anticoagulation for a long time. So she came 5 years later with structural degeneration. And just look, the valve is thick, but we no longer have a soft echo density in there. And if you look which leaflets are involved, it's not the same. Oh, PowerPoint has stopped working. That's usually not a good sign. So we will let it recover. That's okay. We'll all survive. So let's go. So the gist of the story, the short story was that really the patient had degeneration in 2 leaflets that were not exactly the same as the 2 leaflets that were thrombosed. So for the longest time, I thought that perhaps, just perhaps, bioprosthetic thrombosis precedes bioprosthetic degeneration. It's just an earlier event. But this patient showed me wrong. So finally, this is a patient who had a gradient of 31 millimeters of mercury and who did not respond to vitamin K anticoagulation for about a month. And about 1 month later, he started having a little fever, and now he has bacteremia. And once he's treated with antibiotics, surprise, surprise, the whole situation resolves. So he's not responding to VKA, but he's responding to anticoagulation. So that tells you that if it looks like a duck, it walks like a duck, and quacks like a duck, sometimes it is not a duck, okay? So it's important to know that. So not every thickened leaflet, not everything that looks like thrombosis is about thrombosis. So what do? I reviewed all the bioprosthetic valve thrombosis experience at Mayo Clinic case by case. And in the end, I thought, screen with transthoracic echo. And if you have a TAVR valve, probably CT is the better way to go. I would say, even if I'm an echo person myself, I would say CT has the edge in that, and probably you'll get a better diagnosis, provided that you have a good radiologist to do the imaging on that. If you have a surgical valve, it's probably a wash. TE and the CT are both good. If you have atrial fibrillation or rapid rates or anything that will make you think, my goodness gracious, the CT is not going to be great, don't go to the CT. It's going to be frustrating to the patient, to the radiologist, and to you as a referring physician. So just better do a TE and do the best you can do. For mitral and tricuspid, probably you should do a TE. So when should you image? So these are the guidelines. We follow the guidelines to the rule because we have Rick Nishimura who wrote them. So he has a special, stick that he pokes you on the hand if you do the wrong thing. And the ACC/AHA guidelines say that you should image if you have change in symptoms or after 10 years of bioprosthetic valve thrombosis. And if you live in Europe, you live by the European guidelines. They were updated in 2017. And they say when change in clinical status or yearly after 5 years. So let's see how that works with our bioprosthetic valve thrombosis. This is from our series, the JACC paper by Alexander. And if you look, you would start imaging here if you lived in Europe, and you would start imaging here if you lived in the United States. And what that means is that you are going to miss about 80% of bioprosthetic valve thrombosis by European guidelines, and about 90% of bioprosthetic valve thrombosis if you live by the American guidelines. So neither guideline is particularly helpful for the diagnosis of bioprosthetic valve thrombosis. So what I think, of course, if you have a change in clinical status, you should image. But even if you do not have a clinical change, we still recommend that you image on a yearly basis, to the very least the first 3 years. At Mayo, we practically image everybody every year with a bioprosthetic valve thrombosis. So that's our practice at this time. And of course, watch for subclinical changes. So what are the treatment options that you have? When we started the project, we had the 2014 and the 2012 guidelines. There was really no section on bioprosthetic valve thrombosis. There were some recommendations for prosthetic thrombosis in general. And what was recommended was that if you have left-sided or in hemodynamic instability, you should go to surgery. And if you are on the right side with small thrombi, you should probably go to lytic therapy. And there was nothing on warfarin. In European Society of Cardiology, the guidelines said optimal anticoagulation. Optimal anticoagulation is a great word. It doesn't say what is optimal. It doesn't give you a target, How when you're a resident, you say, so we treat with beta blockers. Which one? How much? When do I start? So kind of sort of like that. So a third myth that we encountered was that surgery and lytics are the main treatment for bioprosthetic thrombosis. This is what happened with our initial series, the first 30 patients. So if you had mitral, tricuspid, or aortic valve bioprosthetic thrombosis, and you were treated with vitamin K antagonists on the left, or surgery or lytics on the right, what you had was a decrease in gradient to the same degree, from red, time of diagnosis, to yellow, post-treatment. So it turned out that vitamin K anticoagulation actually works quite well for bioprosthetic valve thrombosis. It was certainly as effective as surgery or lytics in this small series. And this is the patient I showed you with bioprosthetic thrombosis in 2012, a little nicer images this time. 2 of the cusps were evolved. And look what happens after 1 month of anticoagulation. You still have a little bit of thrombus here, but you can see much better movement of the leaflets, much thinner leaflets. And if you look on the 3D, there's full opening of the valve. So this is clear evidence that just simple warfarin, we didn't bridge this patient was not symptomatic, we didn't put her on low molecular heparin, just start warfarin, and she did well with that. What do you do though with a patient like this one who presented in Eau Claire just last week, and Rich Hanna was kind enough to share with me? Just look what you have. You have massive, massive thrombus, big thrombus there, big thrombus here, and the gradient across the valve was tiny little 30 millimeters of mercury. I think this is probably the highest I've seen through a mitral valve. And if you look at the transthoracic, you know you have a problem. If the RV is short because of the severe pulmonary hypertension the patient just developed. So in this case, it's probably warfarin anticoagulation for 2 months. It's very, very theoretical. And these are the patients you should decide to go to surgery, or you should do thrombolytic therapy. And after reviewing some of the literature published, we felt at Mayo that really the lessons learned from this Prometheus trial, which looked at mechanical valves, should be probably applied for bioprosthetic valve thrombosis, and this is what we do these days. We do the 24-hour TPA infusion, 25 milligram over 24 hours. If you're successful, you call it a day. If you're unsuccessful, you put the patient on 6 hours of unfractionated heparin and repeat, and check every time after you do a cycle that you have a response. And with this approach, the incidence of stroke or major complication from thrombolytic therapy were actually very, very low. So I think it's a good way to go. Now, I talked about looking at the treatment with warfarin anticoagulation in bioprosthetic thrombosis, and it's all fine and dandy because it's all retrospective, right? And we made the diagnosis based on the fact that they had a response to warfarin. So of course, warfarin worked. So how does it work if you go forward? So what we did in 2014 in January, we had the CV grand round at Mayo, and we shared with the division. We had a common talk with Patty Pellica and Heidi Connolly and myself. We were involved in bioprosthetic thrombosis for a while at that stage, and we shared with the division the concept. And what happens is, after that, we had a registry whereby we want to have communication whenever a tentative diagnosis of bioprosthetic valve thrombosis is made. And usually the call came back to me, so I kept track on that. And what we found was that really warfarin anticoagulation worked. So we had 31 cases by the Google search or 46 by the surgical search in 2 decades. And all of a sudden, we have much more patients, 55 cases in just a little over 1.5 years, so almost 2 years. So it's a lot more than what we thought. And we had in this series 9 non-responders and 3 were lost to follow-up. So did the echo criteria work? Yes. If you had all 3 criteria, the response to warfarin anticoagulation was 38 of 39. If you only had 2 echo criteria, the response was only 4 of 9. So not all 9 patients went to surgery, so I cannot tell you if they were all thrombosed or not thrombosed. The ones who went to surgery did not have valve thrombosis. So probably we tend to overestimate now a little bit the possibility of bioprosthetic valve thrombosis. Now, what happens if you are trying warfarin anticoagulation in a patient? Is it something that's safe? Because the patient will not come to you and say, hey, I have bioprosthetic valve thrombosis, put me on Coumadin. So you have to use your best judgment, and sometimes you'll overcall it. Is it safe to do? And this is, again, work by a couple of our fellows. They looked at all the registry patients, so this is all going forward. So we have now 85 cases of bioprosthetic thrombosis, and they match with 2 to 1 with the patients who had surgery for valve degeneration. And this is what you get. So the success in surgery is obviously 100%. I mean, it's a little overcalled because, of course, you have the perioperative mortality. So some people die even after Mayo Clinic, but we don't capture that. So we did not include patients who had death at the time of surgery. Bioprosthetic valve thrombosis success rate was 85% with warfarin anticoagulation. Death, so these are elderly folks mostly. So it happens. The follow-up was, the median follow-up was almost 2 years. So kind of sort of the same. Stroke, actually, you have a little more stroke with surgery, and that's probably because you stir more things when you put the patients on pump. Now, this did not make significance. Embolic events, you have a lot of embolic events with surgery too, so do not ignore that. So it certainly doesn't seem that warfarin is the bad thing to do. Of course, you pay a price because you have much more bleeding, but only 3% were major bleeding. And reduced surgery, obviously, you have much more reduced surgery because you started with 15% of the patients who did not respond in the first place, and these are patients who are going to have surgery because they did not respond to warfarin anticoagulation. So overall, we felt that warfarin actually worked, and it's fairly safe treatment to do. So then which are the take-home points about bioprosthetic thrombosis? for diagnosis, really, the most important thing is you have to think about it. You are not going to make the diagnosis if you do not think about bioprosthetic valve thrombosis. It is a challenging thing to do. What we know is that bioprosthetic thrombosis may occur late after implantation. We know that on transthoracic echo, they may develop high gradients, but you may not necessarily see what's happening with the valve. You should suspect it whenever the gradient is above 50% over baseline, restricted cusp mobility or thickened leaflets, and do a TE or CT whenever you're in doubt about this particular situation. How do you treat it? For prevention, you want to use warfarin anticoagulation for at least 3 months after all bioprosthetic valves. And we do that including for the TAVR population. So everybody who has a TAVR gets warfarin unless there's a clear contraindication to that. We use aspirin forever once they come off anticoagulation. For NOACs, other than the 12 patients included in one registry, I'm not aware of other experiences in large series that have been published. So we kind of stayed away from it. I think they may work, but we want to see more data on that. And for bioprosthetic thrombosis for treatment, once it occurs, I think really that Coumadin is the first line of therapy if the patient is hemodynamically stable. And of course, if they're in shock, you should do lytics or surgery. Thank you for your attention, and I'll take some questions. So let the grilling begin.
All right. Thank you, Sorin. This was a great talk. 2 questions. Do we have any data? I know at Mayo you guys use Coumadin 3 months after bioprosthetic implantation surgically. Not everybody does that. So do we have any data that using 3 months of anticoagulation prevents later valve thrombosis 2 years later? And then second question is, how long do you treat for? I think that's the thing that we still struggle with. When do you stop anticoagulation for these patients?
So the first question was if you treat longer than, if you treat for 3 months anticoagulation, does it prevent thrombosis down the line? And the answer to that is no, it doesn't. And what the reason to say that is we have patients who scratch the aortic valves. So just don't think aortic valve. Every single mitral valve, tricuspid valve, pulmonary valve prosthesis were treated with anticoagulation for 3 months. I promise you, every single one of them. Yet they do develop valve thrombosis down the line. So being on anticoagulation the first 3 months does not guarantee you will not develop a valve thrombosis in the future. Now, for aortic valve prosthesis, the one paper that made a splash was registry data from Denmark. So Denmark, having had the opportunity of a centralized system, so everybody's under the same insurance, so they can control who's getting what based on pharmacy dispensing of warfarin. So they know for a fact when patients are on warfarin and take it because they refill their prescription. So that registry showed that if you do not take anticoagulant therapy for aortic valve prosthesis, bioprosthesis, the mortality is actually increased. So not bioprosthetic thrombosis, just death is higher in the group that's off anticoagulation. So that made quite a splash in the surgical world. Now Mayo Clinic looked back, and there was a propensity match study, and we said 10 years ago that aspirin is probably as good as warfarin, and Mayo was not the only group supporting that, and that's the reason why the 2008 guideline said for aortic valve bioprosthetic, aspirin is good enough. We changed the practice, so now our surgeons try to do actually up to 6 months in surgical valves. For TAVR, these are frail, and we say 3 months, but on occasion there's fear in the air, and they go on anticoagulation for just 1 month. But as much as we can, we try at least 3 months. So that was the first question. The second question is, once you have an episode of bioprosthetic valve thrombosis, is it safe to stop once you treat it with warfarin anticoagulation? And I don't think anybody has an answer. So my personal practice was to keep everybody on anticoagulation for long term. Was it the right decision? Was it the wrong decision? I don't know. Most probably, if I accumulate large enough number of patients, there's going to be somebody who's going to have a bleed, and I'll feel very guilty about that. Now, there's anecdotal data. So one of Heidi Connolly's patients was licensed pilot, and for FAA, they cannot be on Coumadin. So she needed to come off Coumadin to maintain her license, and she thrombosed one of the cusps. I remember vividly. It was a medial cusp on a mitral valve. Treated successfully, stopped Coumadin anticoagulation, came back 1 year later with thrombosis on the other cusp. So I think we do not understand well enough who's going to have valve thrombosis and why. We started looking at coagulation profiles in patients who have bioprosthetic valve thrombosis, and we do not have we do not have complete data in everybody. We had a couple of lupus anticoagulant, antiphospholipid, so these things do happen. And obviously, if you have that, you'll be on warfarin forever. But the patients who do not have a clearly abnormal coagulation profile, does it mean that they don't have it because we don't know of their mutation, or does it mean that they are having normal anticoagulation? And the answer to that is I don't know. So I don't think there's a good answer.
Do you have any enough experience to comment on maybe differences among the valve manufacturers in this process?
So a few years ago, Hartzell-Schaff looked at the aortic valve prosthesis, and there was the pericardial versus porcine, and the short story of that was he felt that the porcine valve, because the way the valve was designed, allows for stagnant flow at the base, and perhaps that is the reason why in that particular series of 8 patients, he only saw it in porcine valves. Now, we've seen it in pericardial valves a lot. So I think all TAVI valves are pericardial, and we see it on occasion in TAVI valves. So I don't think we've seen a manufacturer that was more prone than the other, or a material that was more prone than the other. Mario.
Hi. Great talk. I wanted to challenge you on one of the things that I found really interesting, because I think most of the people are wondering about the same. So you said you had this one patient had valve thrombosis, later on in different cusps, the degeneration, and that's what, put you away or deferred you from thinking one is the same.
Yeah.
But how, maybe it is the same, and you just missed in between thrombosis on one of the cusps that now is degenerated, right? So, I mean, do you think that these early generations that we see, at least some of them, may have had that in the surgical population? We just didn't know?
It is possible. I mean, as I said, for the longest time, I felt convinced that if you have a thrombus in one particular cusp, that's a kind of a nidus for something to happen. And there's no way for me to prove it one way or the other. It is true. That particular patient, the reason I thought it's maybe different, I kept her on warfarin. And she was pretty good about that, because she had a miserable experience. She came from couple of surgeries before she got the valve thrombosis, with all sorts of complications, all sorts of bad things happening to her. So she was good with the Coumadin, and she stayed on Coumadin for 5 years after the initial event. Yet, she develops the thickening and bulging. The one cusp that looked non-involved looked actually well and had a clear thrombus before. So I don't know. If you explant that, will you see it? I don't know, because we did a valve in valve, so she didn't have surgery.
Good morning. Thanks for an excellent talk. I wanted to push back a little bit on the challenge between what the guidelines suggest versus what you're suggesting. So certainly the guidelines, if you're going to wait 10 years, you're going to miss some early events. But I guess, what's your thought about the point of no return? So if you're going to do annual screening, obviously you're going to pick up a lot more patients earlier, but potentially earlier than you need to affect clinical change. So I'm wondering if there's maybe a happy medium between what the guidelines suggest currently and your current practice of annual screening for the first 3 years.
Well, so it's all about the yields. And if you say, I'm going to take the CT, as I said, I think the CT is a little overestimated. I think 12% it's much. Our experience, if you take the number of implanted valves in the interval that we diagnose thrombosis, our incidence is much lower. It's about 1.5, 2%, up to 5%, depending on position. And the truth is probably going to be somewhere in the middle. I don't know, 7, 8, 6, somewhere in that neighborhood, the true incidence of bioprosthetic valve thrombosis. And then you have to put this, maybe we need to do that analysis money-wise. Is it a worth tool? So in my mind, if you have in an individual patient 1 in 10 or 1 in 15 chance of developing valve thrombosis, and that diagnosis saves you the surgery, maybe that's one thing that's worth doing.
Right, I agree with you. I guess the question, if somebody's developing early on,
yeah.
Are you really, how early do you need to catch it before you're at a point of no return where anticoagulation isn't going to have an effect?
No longer works. Well, so if you look at the gradients that I showed you, so these are 3 months, 6 months, 9 months, 9 to 12 months, and of course it's not precisely 3, 0 to 3, 3 to 6, and so on and so forth. But if you see aortic and mitral valve almost 1 year before, they have higher gradients. So these patients probably, I mean, for all intents and purposes, I would assume that they had subclinical bioprosthetic thrombosis for 1 year. Yet you put them on Coumadin and it goes away. You know? So well, so you could perhaps go 2 years, every 2 years to screening, and then you'll miss the one who got thrombosed at 3 months. I don't know. It's hard to tell. You need to put some numbers and strategy and math on that to see what's the cost-effective way to do it. Other questions? Okay, we all survived. Thank you.
Thank you.